Welcome to this case-based PCR webinar on device closure of challenging atrial septal defect. The webinar is supported by W.L. Gore. My name is Lars Sondergaard. I'm an interventional cardiologist based in Copenhagen, Denmark, and it's my true pleasure to be joined by experts in this field. James Bentham is a cardiologist based in Leeds in England. Gianfranco Butera, a cardiologist from Milan in Italy, and Matthew Gillespie from Philadelphia in the US. Today we got 3 learning objectives. We can have up the slide, please. First, we're going to talk about how to select the right patient for device closure of atrial septal defects. We're also going to discuss potential anatomical risk factors related to this procedure. And finally, we're going to talk about post-procedural management after device closure of atrial septal defect. We want this webinar to be as interactive as possible, so please use the chat if you have any questions or comments during the next hour or so, and we'll try our best to address those questions or comments here. As I said, we're going to do it as a case-based webinar here. So first, we're going to look at the case we're going to use for discussion. It's a 37-year-old female. She's obese. She got a BMI of 40 kilograms per square meter. She got a history of hypertension, but otherwise nothing in her medical history. She's presented recently with dyspnea, and she also has some palpitations. She's complaining of short episodes of tachycardia. And the local hospital did the workup and referred her to due to hemodynamic significant atrial septal defect. On clinical examination, she was fully saturated. There was no sign of heart failure. She had a murmur, a soft mid-systolic murmur at the upper left sternal border with a fixed splitting of the second heart sound. ECG showed sinus rhythm. She had a first-degree AV block with a PI interval of 226 milliseconds, and also a right bundle branch block with a QRS duration of 128 milliseconds. So, of course, she had an echocardiography, both transthoracic and transesophageal, showing she had a preserved left ventricular systolic function. Both her right atrium and ventricle was moderate dilated. RV function had a normal systolic function. TAPSE was 24 millimeter, and there was a secundum atrial septal defect, which measured 13 times 16 millimeter. No sign of pulmonary hypertension in these patients. So I'm just going to show you here a few slides from the images from the transesophageal echo. You see here first a short axis view with a secundum ASD measuring 13 millimeter in diameter. In this view, there's no rim towards the aortic root, but there's a good posterior rim. It's not particularly floppy or flimsy, so it should provide potentially a good anchoring for a device. And if you move from the short axis view to a bicable view, again, you see it's located relatively high, but still a rim towards the SVC. And in this projection, it measured around 16 millimeter in diameter. So maybe I can start here asking you, Jamie, when do we consider these atrial septal defects to be hemodynamic significant?
Yeah, I mean, this is a great case. She's presented with symptoms, I think, is the first key. So dyspnea on exertion would be fairly typical presenting complaint. And then for me, at this size defect, you'd be looking for right ventricular volume load, which would define it being as hemodynamically significant. Presence or absence of pulmonary hypertension is difficult, I think, and we could talk a little bit about that. But in the first instance, that they're the things I'd be looking for.
So just going back to you again, Jamie, here. When we have to make a decision whether ASD is hemodynamic significant, I mean, in the old day, we did hemodynamic assessments for these patients. But today we're more looking at the echocardiography. Can you give us some some thresholds for when we actually consider ASD to be hemodynamic significant, both if you use invasive measurements or we use echocardiography.
I mean, we don't routinely do an invasive assessment anymore in our practice. So we're going to the lab with already that definition in the bag. If you like, for a significant left to right shunt, of course, there are other indications for closing ASD. But if there's right ventricular volume load on the TE, that would be enough for us to define it as significant. The difficulty is with the more borderline defects. So if you're around the 10 millimeter mark, that I think is where there's area of controversy as to which of those defects you close. And over time, I have to admit that right ventricular volume load is, in the borderline cases, is more challenging to know whether or not they're significant. And I tend to not discharge patients around that kind of mark. Even if there's no right ventricular volume load, I tend to follow them. But if there is overload, then proceed to closure.
So why do you follow these patients? I mean, what's the natural history of these atrial septal defects? Will the shunt change over time, or what's going to happen?
I mean, so the clear-cut one like this one, you're going to go straight ahead for closure. The more difficult ones, I think, are when you've got a normal right heart without volume load, but the defect's significant. And we could debate amongst ourselves where we think that we should be closing those type of defects. Gianfranco, any view on that?
Again, very interesting case, and it is a case that we should encounter frequently in our daily life. I agree with Jamie about the indication of right ventricular overload. Sometimes it's straightforward, I mean, to see that there is dilatation of the right ventricle, but sometimes things are more borderline. And then my question for you and and for my colleagues, is there any role for MRI, for example, I mean, in a borderline case to rule out if there is a right ventricular overload or not? I see that it's probably another exam to be put into the workup up of those patients. But sometimes, in particular, when because risks are always possible, then having a stronger indication could be useful. And finally, I would also underline that there is still some role for hemodynamics, in particular in extremes of life. For example, in patients older than 50 or 60 years old, in order to check for left ventricular diastolic dysfunction, or in younger kids when symptoms are a bit confusing. For example, 3 years old with reduction of growth, or symptoms that may be very confusing, a little bit breathless or things like that. Then in the presence of right ventricular overload, I think there is still a role for giving a more objective view on the hemodynamics of these patients.
So Matthew, I mean, this case looks to be quite straightforward. I mean, a good size shunt and also dilatation of the right side heart chamber. But if you, as Giovanni was saying, if you have a case which looks a little bit more borderline, and also if the patient present very early in life, what will your approach be to those patients?
Yeah, great case, great discussion. What I've seen over the last 20 years in my own practice, and I would say more broadly in the United States, is that if there is a significant anatomic defect that's present with a left to right shunt, and by significant, in my view, it's 5 millimeters or greater, and there's a left to right shunt, it will be closed. And we don't wait around for volume loading on the heart. And the reason for that is that what we've learned as you follow the natural history of these patients, as the left ventricular and diastolic pressure increases, you can get a significant shunt even through a small atrial communication. So what has invariably happened as our technologies have improved and as we've come to understand the safety profile of the catheter-based devices is that really has influenced us towards being more aggressive to eliminate chronic volume load in these patients, to eliminate the possibility for long-term problems. So a patient like this at the current age would most likely in the States have been caught somewhere around age 3 to 6 years old when the murmur became apparent, and that patient would be treated and the ASD would be closed often before you see a large volume load on the heart.
So what you're saying is that even a defect which is not shunting a lot early in life will shunt more as the patient get older because LV diastolic function or LV compliance is decreasing, and thereby will go for a further shunt. So what is a typical, I mean, this patient was mid-30 before she presented with symptoms. Is that a typical natural story of an atrial septal defect?
Yeah, that's the sort of the second, third, fourth decade of life. If you have a large left to right shunt, that's when you'll start to see patients having symptoms. And the issue with waiting to close to that point is that you can really, if you look at the natural history of ASDs, at the original natural history studies, it's striking to see how life-limiting in terms of life duration and quality of life a shunt can be. And it can catch up with you in your 30s and 40s to the point where you have debilitating arrhythmias or debilitating pulmonary hypertension related to the volume load. So atrial septal defects in the current era, we close them routinely in children, and we're not seeing, in most cases, the long-term sequelae now that you would see in the 50s, 60s, and 70s of a chronic left-to-right shunt at the atrial level.
So Jamie, let's say that you missed a defect, like in this case, early in life, and you discovered here she's still not a very old adult, but still younger adult patient. Will she be cured after ASD closure, or will the damage on the dilatation of the right ventricle or the arrhythmia, is that going to persist? Do we know what the effect is of intervening in this age?
Yeah, I mean, just coming back to Matt, I'm intrigued that they go down to 5 millimeters in the US. Wouldn't be my experience in Europe, that we would tend to follow those defects a little more until there's more certainty that we think the defect's going to be important for the long term. So that's an interesting point of controversy, I think. For this lady, yes, she should get a very nice result, and you'd expect the right ventricle to fully recover and her risk of arrhythmia at this age to return as close to baseline, as possible. It gets more difficult, of course, in the older age patient, or even when there's onset of atrial fibrillation that's established. We'd refer those patients typically for EP advice before closing the defect, but would still be looking to close the defect through into 7th, 8th decade, because carrying a shunt that's significant, carries a lot of symptoms with it. And even in older patients, you would expect symptomatic benefit from closure.
Mm-hmm. So, Gianfranco, I mean, if you go for this early closure of an atrial septal defect you believe is significant or will become significant, what is there any lower age, weight, or body size before you can actually do catheter-based intervention in these patients?
Yeah, thanks a lot for that question and very interesting discussion. The weight and the body size of the patient at which we would close ASD depends also upon the size of the ASD and the clinical status. So usually, as told already by previous speakers, the age at which we do close the ASD in an elective way is between 3 or 4 and 6 years of age in my country, let's say. So in before schooling age. obviously if it is discovered before or at the time of life. On the other way, when it is found older, we should go for closure at any age. In terms of lower age and the lower weight and body size, there are a few situations where we do close the ASD before 4-6 years of age, and then there are very few instances, as in patients with prior to liver transplant or prior to brain surgeries, where performing an ASD closure is prophylactic in order to avoid stroke or paradoxical embolism related to these surgeries. I've been involved, I've been closing ASDs in kids of 4 or 5 kilos of weight before liver transplant. Obviously, these were smallish ASDs, 5 to 8 millimeters, where it was possible to perform an ASD closure with some types of devices by using a 6 French sheet.
So for you say for the small children, we have to, of course, to look at the size of the defect, and also what is the size of the atrial septal defects, the septum. So there can be some technical consideration. What if you go to the other end of the scale? If you go to the elderly patient who is, let's say, 75 or 80 years of age, who is presenting with a significant atrial septal defect, will that patient benefit for intervention late in life? Matt, what's your take on that?
Yeah, so at the extreme ends, it's controversial, right? Both as at the extreme young, extreme age, and usually that's a conversation with the family and with the primary cardiologist about what is the current quality of life. I mean, all 80-year-olds are not the same. We have some 80-year-olds that are more active than some 40-year-olds, and so we've had. So how we do this is I take that on a case-by-case basis. I think the older patients for sure in the published experience and in most trial experience are going to be at higher risk, in particular for post-closure arrhythmias and AFib. So if they don't have AFib, it can bring out atrial fibrillation. So I think the arrhythmia burden is higher in the older patients. So you have to sort of have an understanding of that and their risk profile for atrial arrhythmias related to the device. We've seen that with the Amplatzer and with the Gore family of devices. But I don't have a rule, and we don't have limits. We, just last month we closed a sinus venosus ASD in a 75-year-old. Which would ordinarily 5-10 years ago, I would have said, leave that alone. I would not send that patient to surgery. But as we're getting smarter and we're able to do things in a less morbid way for patients, it's invariably affecting our indications. But it's still, I don't think there's enough data to say one way or another what's right or wrong. It seems to be, in my experience, a case-by-case discussion.
So selected patient may potentially benefit from treatment even late in life. Yeah. Sure. There's a question, Jamie, in the chat here. Patient with an ASD which got a left to right shunt. Is that patient at risk for stroke? And if so, what is the mechanism behind that?
That's a brilliant question, because typically this isn't a group that presents with stroke unless there's another mechanism at play. So ASD and stroke just gives you concern for what's going on with the RV and RV compliance and what's caused the shunt to be right to left. So you might see that type of situation, say with Ebstein's or another right heart issue, but ASD per se occasionally can, but it would be unusual to present with stroke.
But can the mechanism whether it be the same as for a patient for Amnovale during a Valsalva maneuver? You change the pressure for for a short while, and the shunt will revert and potentially can cause a stroke if you have a clot in the right atrium.
Yeah, of course. Anything's possible, but it wouldn't be typical. And the mechanism I think is different with PFO than with ASD. So yeah, we see it from time to time, but I wouldn't say it was the common mode of presentation. Much more typical, this type of story of exertional dyspnea, onset of palpitations, that you'd see for ASD.
So Gianfranco, if you see, we can discuss the case you just saw here, but also other cases. Which are the cases where you cannot close the defect? Is any anatomical consideration? We saw this specific patient had good rims, but there was no rims towards the aortic root. Can you tell us about what kind of patient you should disregard for device closure?
Yeah, all kind of devices available in the market right now have similar mechanisms in terms of discs which are going to be opposed to rims. So we need rims or walls or any kind of supporting anatomical area to keep the device in place. Dealing with atrial septal defects, we can treat safely the secundum ASDs with these kind of devices. And rims should be good enough, in particular, except the aortic rim, where we can deal with even an absence of the aortic rim. Later on, probably we should discuss about the intrinsic risks related to the absence of aortic rim with several types of devices. So if the other rims are absent, so towards the AV valves or coronary sinus type ASDs or inferior vena cava rims type ASDs, so in those cases it is, except a few exceptions or anecdotal exception, it is not possible to perform an ASD closure by using the devices available. A different discussion or a different situation is the one of sinus venosus, superior sinus venosus atrial septal defects, but this is not matter of our meeting today.
Okay. So Matt, a more challenging question here. I mean, if patients coming older age, we see that some of these patients have pulmonary arterial hypertension. How to handle these patients, and who could benefit from closure, and who should you certainly stay away from?
Yeah, so this is a point of controversy and really a management dilemma. If they come in and it's gotten to the point where they have pulmonary hypertension related to an atrial shunt, it's usually really far along in the course, and I worry about this being a fixed process and it might be too late. So in those circumstances, I still bring patients to the cath lab, and we do as much pulmonary vasodilating therapy as we can to show that there's some reactivity. So if there is reactivity with, and again, what counts as reactive, we can talk about what is a reasonable change in the relative PVR to the SVR or a relative pulmonary vascular resistance overall. But what I look for is some sort of reactivity, and it's nice if it's still primarily a left to right shunt that you're seeing as opposed to a predominant right to left shunt at the atrial level. And if you can show that you have reasonable pulmonary vascular resistance, and you often, the ASD is too big to really effectively test occlude with a balloon, because the balloon ends up filling both atria and you can't really say much of anything. So I will, depending on the various anatomy, I will test occlude maybe with the device and rerun the hemodynamics while the device is still attached. You can put a device in and pre-fenestrate the device with either various mechanisms that people have described, and certainly work in partnership with my pulmonary hypertension colleagues with the newer classes of pulmonary vasoreactive drugs And so in combination, I usually have one of those folks in the cath lab with me as we do our provocative testing to make a decision about whether or not it should be closed or not. But I think it's a real challenging group of patients. And fortunately, in the States, we're seeing less and less of that, because I think we're far more aggressive upfront in just eliminating the shunt when we find it in the younger patients.
Mm-hmm. So I mean, some people would advocate that if you use this approach, as you said, you treat and you close. I mean, you give them vasodilator, you see that the pressure, like the resistance is going down, and then you close the defect. That this is actually a progressive disease. Isn't there a risk that you may bring the PVR, the pulmonary vascular resistance, down acutely or within the first couple of weeks, but as time goes, the PVR will go up, and the patient will be in a poor situation with the defect closed?
Yeah, I think it's a really difficult situation. But if you get a patient in the lab and they still have primarily a left to right shunt and a tremendous volume load, and then you see pulmonary vasoreactivity on top of that in combination with the newer classes of anti-pulmonary hypertensive medicines are out there, we tend to go ahead and close it, and we would typically fenestrate the device at that time as well. And again, a lot of this is in context of how old the patient is and other comorbidities that are happening. So I don't have a sort of protocol for this. To me, it's very individualized. And like I said, usually by the time it gets to the point that we're bringing somebody to the cath lab, coming with me is the pulmonary hypertension person, and we sort of try to make that decision. Okay, this is what we're seeing. Do we think this is going to be okay? And typically it would be a device that we would pre-fenestrate to give us some level of reassurance that there's at least a pop-off. But does that interrupt the progression of this disease? Historically, the answer would be no, but I have some hope for the newer classes of the pulmonary hypertensive drugs that we're using that maybe we can alter that progression or at least slow it down.
So, Jamie, this patient have no signs of pulmonary hypertension, at least not on echocardiography. But you saw she was presented with palpitations, and she may have a substrate for atrial fibrillation in the future because she had the ASD for 37 years and the right-sided chambers are dilated. I think we all agree that this defect should be closed. If you want to take this patient to the cath lab, is any device more preferable than other devices, having in mind that the patient potentially could develop AFib in the future?
That's a great question. I mean, for me, the absent aortic rim is important here in terms of device choice. Probably more so than issues or theoretical issues around potential AFib. So I'd be looking for the softest device, not looking to particularly oversize. So the device that can close the hole and has the least pressure on the aorta is going to be my device choice.
And because I think quite a few of the patients potentially could come back for a transseptal procedure in the future. I mean, it could be RF ablation, it could be device closure of the left atrial appendage, it could potentially be a mitral valve intervention. So I think also it's important to think lifetime management of these patients at this age, that you also have access to the left atrium in the future.
Yeah, I think so. But equally, you want to make the best choice of device for the patient at the time, rather than necessarily choosing one that's easiest for your EP colleagues to find a way across. And generally, if you talk to your EP colleagues, they can usually find a way into the left atrium, even if you put a device there. So that wouldn't be an overriding consideration. I think more the defect, its position, its rims, and how you think that device is going to sit within the heart and how comfortable it's going to look.
Okay. So maybe we should just look how this patient's ASD procedure was planned. So if you can have the slide back on the screen here. So she was, as we can do for most adults, done ASD closure percutaneously in local anesthesia, guided by intracardiac echocardiography. In our institution, we often use access both in the right and the left groin, because then the interventional cardiologist can work from the right groin and the imaging person can work from the left groin. So I think that's more convenient for everyone. We sometimes do balloon sizing of the ASD, not all the times. And in this case, we plan to use a Gore Cardioform atrial septal defect occluder. So this is a short animation here of how this works. I mean, in principle, you can say there's two types of ASD devices. There are the one which are made by nitinol mesh, and then you have this one of nitinol wires covered by PTFE. So it's a much more soft device, more conformable to the septum. And back to the discussion before, it's probably also an easier device to go through if you later on need a left atrial access for RF ablation, for left atrial appendage closure, or mitral valve intervention. So it's going over a wire like a monorail technique. You form this tulip and bring it back. It's a left disc, and if you're in good position here, you bring up the right disc. You still have the chance to recapture if you're not happy about the position. If you're happy, you can release it. You have this eyelet, which is lock it, and you remove this retrieval cord, and then the device is in place. So it's a quite nice device to use here. And we had the discussion, and will it work on patient with no rim towards the aorta? But we can maybe just go straight here to the recorded case, and we can see how it's actually executed in real life.
So welcome to Copenhagen for this ASD closure, where we're going to use the Cardioform device from W.L. Gore. You saw the case presentation before, so we're going to show in a minute how far we have gone so far. My name is Lars Sondergaard. I'm here with my colleague, Michael Rabeck-Schmidt, and our echo imaging specialist, Niels Weilstrup, and also our fellow here from Belgium, Laurence. So, Niels, before we get started, we just saw the images on the transesophageal echo. What can you actually see on ICE?
Here's the view from the bicable view. And you need to turn medially in order to see the defect. Here it comes. And as you turn more medially and also flex the probe a bit, you can do a short axis view of the septum. And here you see that it's an anterior ASD next to the aorta. So
it's the aorta, we got the round circle there.
Yeah. And so here the trick is to turn the ICE catheter so you go from a long axis view, the bicable view, to the short axis view. Long axis here is not as easy to see, but here it is. It is a quite superiorly positioned ASD. And when you do the short axis, you can see it's also very anterior. So it's an anterior superior ASD in the normal position.
Mm-hmm. So there's no rim towards the aorta as I see it.
No.
Very little rim, but good posterior rim.
Yeah, good posterior rim. And
superior inferior rims are...
adequate. The superior rim is the fat part of the septum, as you see here. But there should be it should be enough to grasp the device.
Can you measure what the size of the defect is?
Yeah, it's 19 millimeters.
19, okay.
So in the meantime, I can mention that we have two measurements now from ICE and from TOE showing that we have a defect, unstretched defect of around a little bit less than 2 centimeters. We'll just verify that with the balloon sizing in a minute.
Now you're across?
Yeah.
And I'm aiming towards the left upper pulmonary vein.
Yeah. So you now, as you want to be, Michael, in that upper left pulmonary vein, so with your catheter, so we can now exchange for a stiff guide wire, and then we can do some balloon sizing. So what kind of balloon is this?
So this is a 24 millimeter Amplatzer sizing balloon. We'll soon see if it's large enough. It should be, because it doesn't seem to be a floppy septum, as Niels just pointed out. So this should be enough for sizing. We'll use a stop flow technique which means that we will inflate the balloon until we see the flow judged by color Doppler stop across the defect by echo.
Okay.
Yeah.
So if you're ready, Niels, I'll try to gently inflate the balloon. Try once again. So if you put some color on and see whether we still have flow across.
Now I would say it's practically stop flow.
Okay.
How much is that? 1.9 again. The distance between the two lower dots is 15 millimeters. As you can see, we confirm the measurement of just below 2 centimeters with this balloon measurement.
So what size device are you going to use here?
Yes, so Lars, that makes us think that we want a device maybe on the upper end of the scale. So we have to oversize a little bit to get a good grip and a good landing of the device. So you could say usually a 2 centimeter hole could be closed with the 37 millimeter device, but in this case we'll aim for the 44 millimeter device to be more certain that we can grasp the aortic rim, because we have virtually no rim towards the aorta.
This is a Cardioform ASD occluder. So just give us a brief introduction to this device.
Yes, this is how it looks when you just unpack it. So we see we have 3 parts. We have the handle, we have the sheath, and we have the device itself at the end. We will now retract the device into the sheath in a moment. But before that, I'll just show you that the handle consists of several parts. There's this protection part that comes in the package. Then there's a locking handle, and there's the slider, which we will use to advance and retract the device from the sheath. So first step will be to secure that the connections are tight, and we'll also, for easy injections, we'll just add this 3-way tap. And the next step will be that we add water to this part, which is a bath where the device is being dipped into before we retract it. Thank you very much.
I can keep it on the saline here.
And in the meantime, I connect the syringe to the injection tube, and we'll just get rid of any air in the system before we start retracting. Good. Then I'll remove this protection bit, and I'll rotate the device a little bit to keep it even further underwater, and I'll start retracting the device into the sheath. So now you can see the device moving into the sheath. Like that. And you can easily feel when you're all the way in. There's a clear hard stop at the end. You can also, if you have a closer look at the handle, you can see there are 2 stops here that you will use when you advance the device. So which will first unfold or advance the device out of the sheath, and then unfold the left part of it, and the third is for unfolding the right disc. So I'll de-air it even further. So at the end of the sheath, you'll notice a small hole at the end, of course, and a hole just close to it, which is where the wire will exit. So it's like a monorail system that the wire remains out of the delivery system while we advance the sheath.
So you just introduce the guide wire here at the end, and it will come out of the side hole.
Yes.
Yeah. So I'll flush here as you insert it into the sheath.
Yeah. And as you can see now, the tip of the sheath is visible, and we are now across the defect.
Yeah. You can also tell us, Niels, how deep are we?
I think you're a few centimeters in now.
Yeah. Should we come a little bit deeper, maybe?
Yeah, a little bit deeper.
Okay.
Okay.
And we can.
So now we can remove the wire. Good. We have the sheath across the defect. We're ready to deploy the device. It seems to be in a fairly good direction. We can correct that, of course, when we try to position the device. So first thing, while I deploy the part of the left disc, you need to remember that the device is coming out and of course requiring more space at the end. So we need to retract the sheath a little bit while we start advancing the device. So I'm retracting the sheath to keep the tip of the whole system more or less in the same position. So now this was the first hard stop. I'll advance further and you'll start seeing the left-sided disc.
And you can also at the same time do a little bit of clocking on your two. You see that's going to move it more posterior.
So we'll try to get perpendicular to the defect. And now we have the device unfolded, so you have the full left side disc unfolded. We have part of the waist unfolded. And I'll retract the device into the hole and I'll try advancing the right-sided disc now from here.
Mm-hmm. So let's go to you, Nielsen. You tell us what you see on your.
So here you see the defect from anterior posterior. So you have aorta anterior and the posterior part of the septum to the right, and you can see that the posterior part of the device is splayed up. So the right-sided disc is on the right side and the left is on the left. And similarly, near to the aorta, you see splaying across the aorta. So the bicable view is like this. So now it's no longer the aorta you see on the top of the in the left side of the screen. This is the right pulmonary artery.
At 5 o'clock.
Yeah, at 5 o'clock. And in or to the right on the screen, it's the inferior part of the septum. And you see the same kind of image here, that there's splaying inferiorly, and superiorly you get the impression that it has grasped the superior rim of the ASD.
Yeah. And if you put some color on it, can you see whether there's any residual shunt?
Superiorly, you don't see any residual shunt. Inferiorly, there do not seem to be any shunt. And then we can do anterior posterior. So now we put aorta into the position, center of the image, and here is anterior part, no shunting across, and then posteriorly, no residual shunt.
Any tuck test? What's recommended with this device? Or should you just go for it?
Yeah, so I think, as with all devices, if you're in doubt, it's better to do a tuck test to be sure, be certain that you are in the right position. We can try and do that as well. We'll just do it gentle because, as it is a soft device, of course, there's the risk of pushing or pulling it through the defect, but still, this is definitely doable. You can see the two discs. Now I'm pushing the device a little bit. You can see the discs moving a bit closer to each other on the right side of the device. I mean, the right from the patient's view. And when I pull a little bit, you can see them moving further apart. So this is behaving like we expect it to.
Yeah. So what are the steps for releasing this device?
So the important thing about releasing this device is to keep the handle absolutely stable. So, and the easiest way to do that is to put your hand behind the handle and then retract the locking handle here. So in that way you avoid pushing or pulling the device while you release it. You'll also see, as soon as the device is released, that the device jumps into position and probably aligns better with the atrial septum, and some of this splaying may disappear, in particular on the posterior part of the device. But the important thing, as I said, is to just keep the handle stable while you do that. So this is the next step I'm doing now. And I'm retracting. Yeah. And there you see the device jump
as you
back
said,
into
you
place.
can see it tilt a little bit as it was
Yes,
released,
exactly, Lars. That's what we want to see. You can see on the ICE images as well that you have a perfect alignment in the posterior part of the septum.
Maybe you can just take us through the eyes once again, Niels.
So again, now we are looking anterior posterior, and you see better alignment, especially inferiorly where the two discs have moved closer together. And when we do the long axis view or the bicable view, it's even more aligned with the discs very close together, and they have definitely caught the superior rim and the inferior rim.
Yeah, very nicely shown here, the inferior rim.
So the final release you do by unlocking the cord from the handle, from the slider here, and just opening it and turning it, and then, well, of course, watching what happens here on Fleur, you retract the cord.
So you're just gently pulling the cord back, Michael, here. Yeah. And you can see that the catheter is still all the way up to the device, and as soon as the cord is out, you see that the catheter, like this, will fall away from it.
Yes.
So now it's fully released.
Yeah.
Any final comments from you, Niels, on what you see on ICE?
No.
Looks nice.
Yeah.
Good. So I think, Michael, this was a very nice demonstration of how to very simply implant this device very step by step. So thank you for joining us.
Okay, so that was a demonstration here of using this Cardioform ASD device. Jamie, there's a few questions from the audience. One is, you saw that here on transthoracic and transesophageal echo, it was measured somewhere around 13, 16 millimeter, and using a balloon, it came up to 19, even though you use this stop flow. Will you always underestimate the size of the defect if you do not use balloon sizing?
Yeah, I mean, it's interesting, isn't it? My experience now, I mean, we do balloon size currently, but I'm finding that the balloon sizing is fairly concordant with the TOE, and it's not really adding much. It gives me a little bit more confidence with deploying the device, which is why we're still doing it, given that we're, still feel a little bit that we want more experience with how the device, is going to sit and perform. But it's interesting that it was a few millimeters bigger. I think the device choice was spot on, Lars. So we would have gone with the 37 fairly early in our experience, but found that we probably ended up upsizing to the 44. It'd be interesting to hear what Matt has to say about that. But the final appearance is absolutely superb. Exactly what I'd be hoping for with the deficient aortic rim, a device that sits low profile and doesn't look to be exerting undue pressure on the aorta.
Yeah, we can hear what you think, Matt, about this.
Yeah, great. First of all, great case. Very, very nicely done. Very nicely demonstrated. With the Gore Cardioform atrial occluder, the question of which size device is really an evolving one and an interesting one, because if you balloon size to 20 there, as you did, theoretically you could have that would be in the top range for the 32 millimeter device. So you jumped over 37 to 44, and the reason that you're able to do that is that it is a softer device, as you said. So the waist itself accommodates to the size of the hole instead of forcing the hole into the round, and that's part of what makes it theoretically a gentler device on the heart. One of the things that I use, I still balloon size as Jamie does, mostly because I think you learn a lot about the surrounding tissue that you're working with through balloon sizing. So I'm very comfortable doing that, and I think you do gain more information and it helps you make the decision. The other piece of information that I think is really important to have before you get into the cath lab is the absolute maximum atrial septal length in the subcostal view on transthoracic echo going in, because that is the dimension at which you'll see the atrial septum at its longest. And you want to know that going in, because just like you did in this case, if you know you have 46, 48 millimeters of total septal length, you can jump up two sizes on the device like you did from 32 to 44 and have plenty of room. And having that extra size disc on the LA side of things allows you purchase behind the aorta, in particular when there's a bald aorta. And it makes the deployment really straightforward, just like in your example. You were very stable on the back of the aorta there as you formed the RA disc. And it was a one-shot deployment because you're able to oversize with this device, I think, more safely than the wire weave platforms that are also available.
Yeah, so despite the oversizing, it's still a very flat device. It doesn't get this mushroom shape as some of the other devices. Gianfranco, there's a question here about using a balloon for sizing. Is there any risk that you're going to damage the aorta with a balloon sizing?
Yeah, so thanks a lot for that question, and thanks a lot for this great demonstration. I don't think, in my experience, that there's never been damage on the aortic root before because of balloon sizing. And I've not heard about that in the literature or during discussion with colleagues around the world. So I think with the balloon available, there is no risk of such injury. And I do think that the balloon sizing or balloon interrogation of the septum, let's say, gives us a lot of information, as already said, about the consistency of the tissue. And with this device, the beauty of this device is that finally the waist is going to adapt to the defect. So actually, we cannot really describe the use of this device in that special type of size of ASD as an oversizing, because finally the waist is not going to overstretch the defect.
Jamie, there's also a question here. One of the attendees noticed there was some smoke in the atrium. So what kind of anticoagulation will you give during the procedure? How much heparin you target a certain level of ACT, or what's your regime?
I mean, we typically give an adult patient 100 units per kilo, stopping at 5,000, unless they've got additional risks when we'd give 7,000. But 100 units per kilo it would be how much we'd use. We'd start them on aspirin pre-procedure and aspirin for 6 months post-procedure, unless there's additional risks for thromboembolic disease, when we'd probably start dual antiplatelet therapy.
So aspirin for 6 months. Is that the same in Philadelphia and Milan?
Yeah, exactly as Jamie said, 100 per kilo heparin, try to keep the ACT above 250. Typically give the heparin, check the ACT as we're crossing into the left atrium to make sure that we're above that 250 threshold. Everybody gets pre-treated with aspirin. Everybody gets aspirin at least for 6 months, and the addition of Plavix if there's any other thrombosis risk factor.
Exactly.
Do we need to be concerned
from my side? Sorry.
Go ahead, Gianfranco. Sorry.
See, exactly the same from my side. Just a question for all of you. What does it mean for you to pre-treat the patient with aspirin? In my center, we do give the aspirin the day before, just the day before the procedure.
Yeah, that's what we do. It's usually the night before. They'll come in the day before for pre-visit, and that night we have them take a dose of aspirin.
Just a couple of days before for us.
What about endocarditis? Is there a risk of endocarditis? Do the patient need to have endocarditis prophylaxis after device closure of an ASD?
Until the device is endothelialized, the patient is at higher risk for having an infection. So typically what I try to do is counsel patients to, if you're having dental work done, have it done before the procedure, or wait for 6 months to a year after the procedure to ensure the device is endothelialized.
Yeah, single dose of teicoplanin during the procedure, or another anti-staph antibiotic, and then pre-procedure dental work, and try to avoid it after. Interestingly, I've not seen endocarditis on an ASD device. I had 2 devices where we've seen clot on the device, but we're following about 600 or so ASDs now, and have never seen IE.
So you said you're following a lot of patients with ASD, because there's a question here. What is any residual shunt 2 days, 48 hours after the procedure? Why are you following it? Is it due to residual shunt? Or why do you want to see these patients back in clinic?
Yeah, I think that's a really timely question. We've just changed our practice quite recently, but because of all the concern around erosion, a lot of the patients that we discharged, in fact, we brought back into routine follow-up, but we're not finding anything other than acquired heart disease in the older patient group. So we've consolidated now to a echo before discharge, which is usually the following day. Sometimes we will do same-day discharge if we do the case in the morning. Then we do a 6-week follow-up, a 1-year follow-up, and then we do 2 device clinic follow-ups at 3 years and 5 years, and then discharge. And happy to be challenged on the 3-year and 5-year, what we're trying to achieve. Obviously, the short-term follow-up is to look for early complications, residual defect, obviously next day pericardial effusion and device embolization. But in terms of the long-term, I'm not entirely sure exactly, whether that's necessary.
So what about you, Matt and Gianfranco? You have how is your follow-up regime?
Yeah, so it's a really good question, and it has been evolving with our understanding of the devices over time. So, in the States, we have 2 families of devices available only. We have the Amplatzer family, and we have the Gore family of devices. And I follow both of those patients for at least 5 years, but for different reasons. The Amplatzer, because of the sort of risk in the known risk in the background of erosion. So I think that's still an unknown that at least I don't completely understand the patients who are exactly at risk. So I follow them for a 5-year window, and even some beyond that if I'm seeing something on echo that is concerning to me. For the Gore patients, I have less concern about erosions, but I think these devices are still pretty early in their development. There is an issue of wireframe fracture that we're following patients for. I do not believe it's going to be clinically significant, but because we don't know yet, until we have that sort of 5 to 10 year data, I'm following my patients just annually for the first 5 years, and then moving it off probably beyond that. Once we're coming up now on 5 years with the Amplatzer or with the Gore Cardioform atrial occluder devices. So I'm not seeing any clinical sequelae in a few hundred patients. So I'm probably going to loosen the reins a little bit in follow-up. But my practice has been influenced by what we learn about these devices as we move along together.
Yeah, and in my center, we do the same, roughly the same as the 2 previous speakers. The only difference is that we do not discharge the patient, and then we continue following them every 5 years. Because I think that even if Amplatzer devices, for example, have been used since 25 years, we do not know exactly about the very long-term follow-up. And then it makes sense, to keep them even updated about what's new is coming out. So again, Italian patients are usually happy to have a doctor taking care of them.
Okay, so there's one question I'm going to answer, because there was a question how to get the short axis view with eyes. If you have a probe in the right atrium, you're going to have this kind of a bicaval view. If you tilt the probe and you go towards the tricuspid valve, you're often going to have this short axis view here. So I think we're coming to the end of this webinar. So I hope it was useful for you how to work up these patients, to identify patients who are suitable for closure, and which patient you also should be concerned about before you close it, to demonstrate how you can do it very easy, sleek with this new device from WL Gore, and also how to manage these patients afterwards. So, Jamie, Gianfranco, and Matt, I want to thank you a lot for a great discussion. And I think I learned a lot here during this webinar. I hope the same for all the attendees, and thank you for attending. And finally, thanks to WL Gore for supporting this PCR webinar. So hope to see you all soon in person. Thanks.
Great. Thank you, Lars. Great job.